Just want to introduce Dr. and Professor Heike Geduld. She's head of education at Stellenbosch and University of Cape Town. She was previously the president of AFEM and has been absolutely integral in the COVID-19 response, both in South Africa and then across Africa. So thank you so much, Dr. Geduld, for joining us, and I'll let you get started on your presentation.
Thank you, Rory, and thank you, Steve, in the background. And I do want to thank the AFEM Exco for an opportunity to speak about, in these webinars, which I think are incredibly powerful in bringing us together as an emergency care body across Africa. So I'm going to be speaking a little bit about health facility flow and about safety in our COVID-19 response. It's a little bit off what I was given as a task, but it comes out of things that have happened in our response over the last few weeks, and it's been incredibly personal, and it gave me the opportunity to reflect and maybe be a little more conceptual than practical. And just to talk about where we're coming from within Cape Town and South Africa right now. In terms of our COVID response, we have about 18,000 cases nationally, which I'm not quite sure what to do with that number because it's a bit of a mixed bag of actively traced and passive traces. But we have about 340 COVID deaths in South Africa at the moment. The Western Cape, Cape Town, where I'm from, is the epicenter of the South African COVID pandemic. We have about 210 deaths within our region. We have 1,500 patients who have been admitted to hospital, and 200 of which were admitted to ICU. And right now we have about 100 COVID patients in ICU across the city and about 350 overall in hospital. What is more scary to me is that within our region, we've already had 420 health workers infected, and we've had 5 deaths of healthcare workers. And we're really only in the first few weeks of the COVID community spread within our setting. And that's what's kind of driven our thinking around our COVID response over the last few weeks. Just to start with in saying COVID-19 is like nothing we've ever dealt with before. This is not normal. And I do think it could be both the worst and the best thing that happened to our health system. The worst because it exposes our vulnerabilities in terms of resources, but the best because it makes us question everything that we've done and gives us the opportunity to re-engineer our health system for the future. So it's an opportunity for us to not simply respond as we have before, but to respond to make things better. And a critical part of how we respond to COVID-19 is really to maintain a functioning health system, particularly for those patients who don't have COVID. And that's what we need to be thinking about when we set up our health system response. So talking about patient flow and movement through our health facilities, and in particular movement through our ECs, why is this important? And we spent last week doing screening, and now we're moving into something that is fairly spatial. But flow is one of the mechanisms for creating a safe healthcare facility for ourselves as healthcare workers, for our patients. But it also creates an efficient service and allows us to care for as many patients as we can. And I thought that before I described screening and flow and the context that we're in, I thought we should talk about the concepts that influence our thinking about patient flow and movement. One of the things we've learned in the last 8 weeks, which is really how much time we've spent on this in terms of thinking, is that we have to change our thinking. We have to be agile. We have to be fluid in how we do things. We have to respond to changes in our healthcare system and our processes as we learn more about what the disease looks like in our communities and how we extrapolate external evidence and experiences to an African setting. But the biggest problem really about this is that everyone brings risk to a healthcare facility. Not simply the patient with COVID. The staff members, it's the visitors, it's the maintenance people. And that risk is real. And as healthcare workers and as individuals within that facility, we are all individually and collectively responsible for our safety and for the safety of those around us. Atul Gawande does a beautiful New York Times article about how they responded as a community within their hospital, and the slogan of, I protect you, you protect me, which underpins how they've responded. And I actually feels like a very African slogan. It has this sense of Ubuntu. We are in this together. We need to protect ourselves. We need to protect the person next to us. So the aim really is to maintain the integrity of the health system as far as possible. We want to rapidly identify patients with COVID disease, and we want to keep staff safe and keep all patients entering the facility safe. And in this way, we keep our communities safe. So we have to really think about the risk to ourselves and to our emergency centers when we think about patient flow and patient movement. Last week was all about screening, and screening really is critical. And initially, this approach for screening and the response is really about an external-facing community type of screen. We use screening in the health system to identify how many cases are in the community, to find those cases, to test them. And that kind of screening based on the case definition is great for doing what it does, identifying those cases. It's not good for managing the front door for an emergency center. And the problem with screening is that the case definition is inadequate. We know that not all patients with COVID have respiratory presentations. And even more scarily, we know that up to 8% of patients who are COVID positive may be pre-symptomatic or asymptomatic by the time they enter your facility. And screening is not just for patients. It's for everyone entering and working in the facility. I'm not going to talk much about occupational health screening. I think that's a really important topic and something we need to examine in further webinars. We're going to talk about how that affects our flow of patients into our emergency center. So this is our current adult EC screening tool. And I'm saying current because it's changed 4 times already in 8 weeks, and it'll probably change by next week. And what it does is give us simply a way of thinking about risk, about maintaining that front door of the emergency center, which is the entrance to our health facility. And really, it's based on 3 things. The first of which is the WHO case definition, or in our case, we have a national NICD case definition for COVID, which still speaks about contact and local transmission and healthcare worker or contact with positive patients. And then our typical case definition of respiratory symptoms: fever, shortness of breath, cough, and sore throat. But what we've learned over the last few weeks is that we really need to add those alternative COVID presentations: general weakness, myalgia, nausea and vomiting, diarrhea, irritability, loss of smell or taste, so we can get a bigger picture of the presentation of COVID. And then something very specific in our context within the Western Cape is that we've added red flag presentations: young strokes, chest pain. These are the COVID presentations that we've missed in the last few weeks. And these are the ones we want to create a greater awareness for. As I said, this is this week's tool. Who knows what will be next week? And so this is how we use it. So what we have is someone at the front door of the facility, which is what we all have, someone who I direct where patient goes to. So what they do is they use the screening tool and the presenting complaint. So I've come to hospital with a letter from my GP that says I have a broken leg. That's great, but I still get screened. So the screening tool asks me about my presentation. I screen negative. I have a broken leg. So I have a low probability of COVID, and I go towards the low risk stream, where I get my normal SACS triage and I get medically evaluated by staff who are still protecting themselves with masks and gloves. If I'm coming to the screening area and I present with features of a pneumonia, I get screened, I have a high probability of COVID because I have a respiratory presentation, and I rapidly get moved towards the high-risk COVID area. And I get a COVID evaluation with staff in full PPE. That's the severity score, supplemental oxygen, and all of the things about management we'll speak about in the future. Those are the easy ones. The challenge is that gray area in between. Those patients who present with non-respiratory COVID symptoms or red flag presentations. Those ones need a little more thinking. So they need some sort of medical screening by appropriately protected staff. And this can be a senior nurse or junior doctor or whoever is designated to figure out and just make some sort of clinical evaluation as to whether this person is high risk or low risk. And we're very clear that it isn't COVID and non-COVID because we can't be sure, but it's high risk and low risk for COVID. And within those streams, it's important that both the low risk and the high risk patients are isolated from each other. So you can be in the low risk group and still need to sit a meter away and have adequate ventilation, because somewhere in there may be a COVID patient. So wouldn't it be great if we could simply test and make sure that the screen is actually COVID and non-COVID? I mean, many of the guidelines that I've seen, and even some of those that I had developed early on, it really was COVID, non-COVID, as if those were very clear cut, that we could test and we could know what was happening. And in the words of Inigo Montoya, testing, I don't think it means what you think it means. Because our current testing system is not adequate. The current PCR for COVID, if you have access to it, is really only detecting about 2/3 of cases if you're using a nasopharyngeal swab. And the challenge with that is, you could have a patient that tests negative, but 30% of those patients who've tested negative on your swab are still COVID positive. And that is a very scary number. And that is very risky for us if we're using testing to delineate almost clearly COVID, non-COVID. But for many of us, testing may not actually be available, or the test results may be delayed for days or weeks, so that you're managing patients without a test result. So in reality, there are actually multiple streams of patients trying to get into your facility. Those who have tested positive, the known COVID patients, those who have screened positive and have been tested and are now awaiting results, the persons under investigation or PUI. Those who have screened positive, they're not tested because your test isn't available, so you'll treat them as positive. Those who have screened negative but have COVID, and those who have screened negative and don't have COVID. And unfortunately, you can't tell who they are just by looking at them. And one of the challenges that we have is that as test availability decreases, particularly in our setting, where testing is not available, as our case numbers go up and we hit the peak of cases where we are completely overwhelmed, it may be worth treating everyone who comes into the facility as potentially positive, because we won't really have the capacity to delineate those streams clearly. And we know that if that happens, it's going to have a significant resource implication for us. We're going to be using a lot of PPE, but that might be the only way to keep all of us safe within this pandemic. One of the other ways that we can keep ourselves safe is rethinking about how we interact clinically with our patients. What is the stuff that we do every day that we have to change in order to keep us and the patients safe? So this together is our clinical evaluation of suspected or confirmed COVID patients. Emergency medicine has worked with internal medicine to try and develop a kind of standardized, safe approach. And this is a remote care approach. What we're saying is, if you think someone is potentially a COVID-19 patient, first thing you do is make sure that as the healthcare worker, you are appropriately protected with your PPE and you maintain a distance from the patient. You're doing a lot of eyeball medicine. If you think the patient is symptomatic, you give them hand sanitizer, let them clean their hands, let them put surgical mask on. The patient doesn't complete any form. They don't touch anything in your environment that you may have to sanitize later. And we try and keep our clinical evaluation as limited as possible. So what we've said that we're going to do is do fairly minimal observations. So we'll ask them to hold out their hand and put the SAT probe on. So from that, we'll get a SAT, we'll get a pulse, we can count their respiratory rate, we can do remote temperature measurement, and we can document how mobile the patient's been. Did they walk to you? Are they in a wheelchair? Are they on a stretcher? And those are going to give us a really good assessment of how severe this patient is. If we are worried about their blood pressure, if they're looking, a little bit flushed, their skin is poorly perfused, you may want to palpate their radial pulse as you put the SAT probe on. But if you think it's necessary, you may need to do a blood pressure measurement, understanding that all of your equipment must be cleaned and sanitized after use. And so this would be our standard evaluation of someone who's a respiratory presentation of COVID. It's minimal, it keeps the patient safe, it keeps us safe. And one of the things we really need to do in a rational PPE environment is think about task sharing. We want to minimize the number of individuals directly involved in care. We want to make sure that someone in full PPE, appropriately protected, is doing the tasks of the doctor, the nurse, the admin, the porter, the cleaner, giving the patient food. because we don't have the opportunity or the luxury of having every single person come in full PPE and engage with the patient. So we may even want to take bloods and do special investigations for inpatient teams to allow them to simply follow up the next day. And it's simple things like learning how to position a patient for mobile x-rays while in PPE. Things that we haven't necessarily had to do before, but we now need to train our people and think about how we share these tasks. The real challenge is that most of our patients coming through our emergency centers throughout this pandemic response will be PUIs. They will be persons under investigation, and we will manage them without a test result. And the part of the challenge is that we need to make space for all of these different streams, for the known COVID positive patients, for the PUIs, and for low-risk COVID. Notice I didn't say non-COVID. And we may need to make this admission space for all categories of patients, for pediatrics, for obstetrics, for orthopedics, because there are women in labor who may have COVID. There may be patients with broken bones who may have COVID. And until we make sure that those patients are appropriately isolated and streamed, we are not going to get rid of the risk. And the risk is big. The risk to healthcare workers, both clinical and non-clinical, is large. At present, we are planning for about 20 to 30% staff attrition rate at the peak of our COVID response. And this is staff who either contracted the disease or been exposed and are now in quarantine or have burnt out from the demands of this work. And the vast majority of our current cases of healthcare worker infections, the 450 that we have right now, 8 weeks in, most of them were not from high-risk areas. They're from areas such as labor board and pharmacy and laundry and cleaning and security. And this is the challenge. It's not the patient that is the risk to us as healthcare workers, it's us. And so we need good occupational health policies so that we don't become the ones giving the virus to our patients. This is a real risk to other patients who enter the health facility. It's been reported that up to 20% of patients who entered the NHS with non-COVID presentations subsequently tested positive. That's a scary number. We need to keep in mind frequent screening and testing and retesting of all patients in our facilities. And we need to make sure that as healthcare workers, we have early screening, early detection, early isolation, so that we aren't being the risk for our patients. And these are our tools: physical distancing, adequate ventilation, and hand hygiene. And raising awareness around these is very critical all the way through. If you're like me, you probably have a little bit of COVID fatigue already. It's going to be a long 9 months if I'm already tired of hand washing. And so signage like this one, I really like this one, is important. Is that keeping that awareness going. It's something as simple. So we should think about how we continuously motivate and keep staff aware of their behaviors. So how do we apply these safety principles to managing our patients within our facilities? And it's the most basic things: physical distancing, making sure that in our waiting areas, our patients are 1 meter apart. Try and make sure adequate ventilation, open windows, making sure there are fans in particular areas. If we can isolate patients in single rooms, that's great. But if you're like us, those are very hard to find. We need to limit patient movement. We need to try and do everything wherever the patient really is. And we need to limit contact with patients. And we have had a no visitor policy for the last 8 weeks. And that's hard. That's really tough. We need to make sure that no one is in contact with the patient. And if there are visitors, it has to be for an essential place, and it has to be outside of the clinical areas in a safe and clean space. We need to limit our patient movement. And also we need to create dedicated spaces where patients move. Plan those movements ahead, where all the PUIs and the COVID-19 known patients get transported, and demarcate it, put tape on the ground, have a dedicated lift, a dedicated pathway. Make sure that all of your staff are trained in and knowing how to move around safely with adequate PPE. Make sure the environment is regularly cleaned and disinfected, and make sure there's good ventilation all the way through. I've spoken a little bit about space demarcation and physical space. But think about your environment. What are the particular risks to you? What are the high contact points? Where does everyone go to? To the admission desk, the porter desk? Do they go through a narrow entrance to get through to the security gate? Limit contact for everyone in the unit, not just patients, for staff too. Stagger your staffing shifts, stagger your breaks. Make sure that staff have adequate physical distancing and wear face masks, and manage anyone who's entering you, whether it's maintenance, deliveries. They all need to be aware of the policies for your area. And when the peak hits, or as it is coming for us very soon, we know that we're going to be moving staff to different and unfamiliar work environments. And that can be tough. So particularly in the EC, we need to make sure that we've trained and orientated our visiting staff well to our process. So physical prompts, signage, posters, demarcated areas are useful because they take some of that cognitive workload away. You may want to use a buddy system by making sure that staff from outside have a buddy who's worked within the EC environment and knows the processes. You may appoint a safety officer to ensure that everyone is following the behavioral and IPC strategy you have. But it's a collective responsibility. And a really important part of that is making sure that we have a culture that is open to everyone collectively being responsible for others' safety. We need to make sure that the porter can tell the head of the unit that they've touched their masks and now their hands are dirty without feeling like they're going to be abused. And the risk awareness is for all areas, not just the clinical areas. I'm not going to talk about IPC and PPE, which is outside the scope of this talk, but I want us to think a little bit about how we behave in our clinical spaces. In EM, we really do see ourselves as social tribe awareness. We're very sociable people, and so we tend to huddle. We tend to move around patients' bedsides. We tend to take tea together, take breaks together. This is the kind of behavior that's risky within this pandemic. So think about your particular risks in your environment. Think about your environmental hygiene, your bathrooms, your lifts, your doors, your phones, your pens, the things that you do without thinking. Those are the ones we want to make sure we can manage. This is some of the signage that we have around in different hospitals across the province. This is the staff tea room precautions, a really important sign in the toilet, and some signage around potentially looking after yourself and not taking the disease home. And there's plenty of these around, but it really has to be part of our response. It's should be part of our thinking, not just about ourselves but about our patients. So COVID-19 really is a threat to our health facility function. And we need to manage this risk through a clearly demarcated flow, through clearly defined processes for all patients in all risk streams. But we have to emphasize the basic principles: physical distance, hand hygiene, and adequate ventilation. We need to have a plan and communicate that plan to all of our staff. And we need to take collective responsibility. We need to look after ourselves and look after each other. And just so that you know, this too shall pass. We will get through this. Thank you for listening, and I'm happy to take any questions that anyone wants. Thank you.
Thank you so much, Heike. So we did have a couple of questions come through as you were giving your presentation, so I'm just going to ask you them now. The first is, why is Cape Town the epicenter of the South African epidemic for COVID-19?
Wow. Let's start with a complicated one.
It's a big one.
It is a little challenging. So there's been quite a lot of discussion around this. First, to say that actually Cape Town has tested more than most of the other parts of the country. So one of the reasons why our numbers are so high is the testing strategy itself, is that we have actively case sort patients. So most other parts of the country have passively sort cases. So people come to the screening testing center, they have symptoms, they get sent, they come and retested. What Cape Town has done has really been very much looking for hotspots and clusters. So when we find a positive case, our city has our public health experts go in and test. And so that's part of what happens. The other theories are really that we probably do have more cases. And it was probably that we had community spread very early on and had missed that. And we, I think we had quite an extensive lockdown. We're still under some degree of lockdown. And what it has done is minimize the number of cases. But it started, we think, too late. That we, unlike many places where the disease came and people were basically getting into contact with travelers, we probably had community spread before we went into lockdown, and now it's really just showing as the lockdown lifts.
Yeah, it's definitely a very multifaceted answer, a lot of moving parts in that. Thanks for tackling it for our attendees. The next one is about the entire approach to overcrowding. So do you think the entire approach for overcrowding will change if time allows in the post-COVID-19 era? And how do we relate our approaches to overcrowding before and after COVID-19?
I think that's a fantastic question. Thank you. Because I think this is one of those health system process things that we've gotten used to that has to change. Sorry, I'm just so in terms of the overcrowding, and I'm just speaking from our local experience. One of the things that this response has done for us is push the fact that we actually have to have time-based ED rules. And this is something we've been talking about for years, that we have to have a cutoff that is going to get overfull, and we've never actually had the motivation from senior management to push back against clinicians or the way that the hospitals functioned. So it's part of our planning now is to say that actually we're not allowing overcrowding for many different reasons for the particular risk. And we're putting in strategies that improve flow that we think is going to last after this. Having a time-based limit for how long people can spend within different components of health facilities is huge. So I'd like to think that you can use the pandemic response to question the way that you've done things for a while and push for changes that will be a legacy after this.
Thank you. And then another one that's related to screening and testing and everything that you were talking about that goes into that, and how do you sort of manage that with a limited amount of tests. What does antibody testing play a role in? Like, is there a role that it plays? Is it a bit too sort of under-researched at the moment? What are your thoughts?
So I'm going to start by saying that I'm not a virologist, but I do have conversations with them. So a lot of this is based on my interpretation of conversations with our public health and virology and infectious diseases group. We aren't particularly pushing for any sort of serology testing at this point. From what I understand, the sensitivity and specificity of the available tests are fairly limited. We're less than 6 months into a new disease. It's really hard to get gold standard tests. And looking at the literature that's coming out of the countries who have been through their peak, the use of serology is actually very hard to pinpoint because we're not necessarily sure that everyone who has the disease is able to make antibodies and that those are measurable and that antibodies even protect against a resurgence of disease. So I don't think that antibody testing is at any point in our future in the next 6 months. And its use has to be very clearly defined, and the tests have to be of a better standard before we would consider it.
Yeah, and it does sound like from what you were talking about that even if there were antibody tests, the safest measure right now is to just pretend as if everyone has it and act accordingly. Yeah. And our last question, and as I ask this question, you can pop in a couple questions more if you want. We have a couple more minutes, but I won't take any more than like 1 or 2 after this one question. So when it comes to different health departments, a lot of them tend to be understaffed or underspaced, radiology, for example. And when it comes to that, the tasks that are being done in those different departments are done by porters, and then each patient remains in one place. That is the ideal, but because there's understaffing and there's lack of space, patients tend to move, staff tend to stay in one place, and that can obviously cause sort of a challenge when it comes to spread and keeping things safe. So what COVID-19 measures have been taken in settings like this to sort of reduce the risk of spread?
I like the way that you start with radiology, because I think that's actually kind of critical. There's very little we actually do to pay for patients otherwise. We've been planning also for an intermediate care bed facility. So within that intermediate care bed facility, we've had to think about in a new, how do we create geological services in a way that is safe. And what we found is that unfortunately it's going to be portable machines that we do. We know we have to create capacity to bring the service to the patients because the risk is much less. So all of our x-rays, particularly around ECs, are being done through portable machines with radiographers who come to the unit and have the same no contact approach. So they've taught the providers, our doctors and our nurses who are in the PPE to be able to appropriately position the patient, put the side behind them, get the patient in the right place. The x-ray is taken, and then the slide is placed into a sanitized bag and then taken away. And those are very little things that we can do, but we've had to realize we have to weigh up the risks of how important is this investigation, because if you contaminate a CT for 8 hours and take out the radiographer, that's not worthwhile. So everything that we do has to be a risk-benefit conversation. Is this important for this individual patient? What is the impact of this across the health system?
Thank you so much. And I think that's all we have time for in terms of questions, but thank you for your presentation and thank you for answering our questions. And for all of our attendees, the presentations will be made available on our website. We're just working on uploading them. So we'll post on our different social media platforms, Facebook in particular, letting you know when those presentations are up. Thank you so much, Professor Geduld. And yeah, we are really grateful to have you and to have you share your knowledge with us.
Thank you, everyone. Thank you for a great series.